Sir, good evening, sir.
Good evening. You are Sahal, is it?
Yes, sir, yes, sir. I'm Mehal, sir, second year PG, sir, MGMC.
Okay. So
Sir,
Anup and Nina will be presenting.
yes, sir.
Yes,
We would
yes.
like to take this opportunity to thank you, sir. In spite of your busy schedule, you are putting lots of efforts to share your knowledge, sir. Thank you so much, sir.
Yeah, no, you see, I'm always for postgraduates. Since my postgraduate days, I always, keep myself in teaching I was teaching the junior postgraduates, then, afterwards, other regular postgraduates when I became a lecturer and, staff. So that is my, hobby like or passion, whatever you can call it. I really
Thank you so much, sir.
like this. If postgraduates can be helped, definitely I'll be the most happiest person.
We want to thank our HOD also, sir, and our Department of Professors for letting us giving this opportunity, sir. We are so
Correct.
thankful to them also, sir.
That is there, just before especially the seniors exams, we almost finished most of these long cases and almost nearly most of the short cases also, barring three or four short cases are remaining. And I think we can finish before their practical exam. So that is going to help them a lot actually, because they are already exposed to what sort of questions that are asked in the exam. So once they know what sort of questions they're going to be asked for particular type of the case, so they're already prepared. They can easily answer and they can answer with confidence. So
Yes,
what is very important is when you sit in front of the examiner is how confident you are in answering the questions. That is what, many I have seen some of the examiners, they look for how confident is the student when answering. Because if he is very confident in answering, they know that he is very confident in managing the cases also. Because actually, ideally speaking, practical means what? Actually, you are supposed to, start the anesthesia part for a particular case given in the OT, and we are supposed to observe, and then we are supposed to ask you questions. But that is not possible. So since it is not possible, we'll be asking you questions as if, and you will be answering as if you are managing the case inside the OT. So that way we'll be doing. So how confident you are answering the questions depends on how confident you are in managing the cases also, practically. So that is what is practicals. Of course, for getting the confidence in answering, you require a lot of theory knowledge. Once you know the theory knowledge, because every day you are doing you're working inside the OT and routinely you'll be working many times without knowing why you are doing what you are doing inside the OT. Whatever your staff or consultant is telling you to do, you will be doing. So what is more important is knowing what you are doing, why you are doing. That becomes very important. Once you know why you are doing what you are doing inside the room, that requires a lot of theoretical knowledge. Then you will be more safe to the patient. And also you can even, little bit sometimes you can personalize your anesthesia to the particular patient. Because what is now thing is, it is not, the anesthesia is not generalized to everyone. It is not okay, general anesthesia means general anesthesia for every patient. So again, it has to be a personalized anesthesia. So to that particular person, to that particular patient. So you have to individualize everything, including your, whatever the pre-medication you gave, whatever the preparation you do, and what type of anesthetic technique you want to go for. So how are you going to maintain the patient, and what is the fluid requirement, and what about the post-op analgesia? So everything has to be individualized to that particular patient. It is not in general. Okay, that is what is very important. And as you improve your theoretical knowledge, so you will start individualizing your anesthesia, technique, drugs, whatever it may be. So, and that is more important. Individualized anesthesia, personalized anesthesia is more important in not rather than just, routinely giving GA, routinely giving a regional anesthesia. So everything has to be individualized. So that is what is more important. So that's you gain a lot of that type of knowledge by knowing more about the theory plus working in the OT. So practical knowledge also will be getting. So with the years, you will really become very, very safe as far as anesthesia is concerned to a particular patient. And that is what we check also in the examination, how safe you are for the patient. Because that is the most important. Safety of the patient is the most important concern when we anesthetize the patient. And one more thing I just want to tell you, because you are juniors, anesthesia is not the treatment, isn't it? Surgery is the treatment. Patient has come to get the surgery done. He has not come to receive your anesthesia. Definitely not. So you should not develop any kind of complications or any kind of side effects because of your anesthesia. That is the most important thing. So that is why the whatever we give, we have to consider the safety of the anesthesia when we manage. That is how when we discuss our cases also, we'll be discussing how safe we can be for the patient for a particular type of comorbidity the patient has, or he can have multiple comorbidities also. Like, for example, now you are presenting today obesity. Obesity patients can have multiple comorbidities. It can be pulmonary, it can be cardiovascular, it can be gastrointestinal, it can be hepatic renal. You name it, they can have everything. It can be cerebral. So you have to consider the patient as a whole, examine the patient from top to bottom and know in detail about the pre-anesthetic evaluation of the patient, and then individualize your anesthesia for that particular patient. Okay, I think what is the time now? Is it 5? Yeah, it's just 5 o'clock. So I think we will start off. So what I want from Nina and Anup is first you present the case. Anyway, you already put the slides. So you just present the case, and because it's a short case, so present it, only the main important points you can always present. Very positive findings in the history and positive findings in the examination. That is what you will be asked also in the exam. So anyway, you just read whatever you have taken the history and examination of this particular patient. Then we'll start discussing. Okay. Okay. Start. Who is going to start? Nina or Ranu?
I'm starting, sir.
Okay. Okay. Right, Anu.
My patient's name is Mr. Chandrasekhar, 58 years old male. He's a bank employee by occupation and he's residing from Chidambaram. He's having weight of, sorry, 1 second back, 110 kgs and height of 170 centimeters and BMI of 38 kgs per meter square. So he came with complaints of abdominal pain since 1 week and complaints of vomiting since 4 days. The patient was apparently normal 1 month back. Then she complained of right-sided abdominal pain, which was dull aching in nature, and it worsened since last 1 week. He had occasional vomiting, which contained of food particles, since past 4 days. He has no history of chest pain, dyspnea, or palpitations, no history of fever, cough, or sore throat, no history of weight loss, night sweat, or fatigue, no history of daytime sleepiness or tiredness. So he went to outside hospital where he was given initial care and USG was done. It showed gallbladder normally distended and normal wall thickness and calculus of size 12 into 6 millimeters with posterior acoustic shadow in the gallbladder lumen. And he was diagnosed to have cholelithiasis, after which he was referred to MGMCRI for further management. So past medical and surgical history, he's a known case of hypertension since 10 years on regular medication on tab Amlong for 10 mg BD. Not a known case of type 2 diabetes mellitus, hypothyroidism, Schizer disorder, bronchial asthma, heart diseases. No history of any drug or food allergies. No history of any blood transfusions. No past surgical history. Personal history is a non-vegetarian diet. Occasional alcoholic for 20 years. Last consumption was 10 days back. Chronic smoker since 20 years and 20 pack years. Last smoke was 4 days back. Normal bowel and bladder habits. Normal sleep pattern and history of snoring is present. To summarize, he's a 58-year-old male, occasional alcoholic and chronic smoker who is a known case of systemic hypertension on medications falling under obesity grade 2 was diagnosed to have cholelithiasis.
Yeah, continue. Yeah.
Okay.
On general examination, patient is conscious, well-oriented to time, place, and person, adequate hydration. Patient is heavy built with a height of 170 centimeter and weight of 110 kgs with a BMI of 38 kg per meter square, sir. Patient came under the grade 2 of obesity. Calculated the ideal body weight, which came to 66.5 kgs and lean body weight of 79.8 kgs. No pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pitting pale edema present. Vitals, pulse rate was 78 per minute, which was regular in rhythm, which had good volume, normal character, no radial or radiofemoral delay, and other peripheral pulses were also felt. BP in sitting position over the right upper limb came to 160/95 mmHg. Respiratory rate of 20 cycles per minute, which was abdominothoracic type. Saturation, he was maintaining 99% on room air. His breath holding time was calculated to be more than 22 seconds. And temperature was normal, 98.5 Fahrenheit. And OSA scoring with stop band was found to be 5 out of 8. On airway examination, neck movements was a normal range of movements, sir. Mouth opening was adequate. Interincisor gap was around 5 centimeters. Myelopathy scoring was grade 3. Mentothyroid distance was 6 centimeters. And upper lip bite test was grade 0. Patient did not have any loose tooth, fixed dentures. Spine examination was able to feel the spine, but it was leap-seated. No kyphosis or scoliosis. Skin of the spine was normal. Systemic examination, CVS, S1, S2 was heard, no murmurs. RS bilateral air entry was present, normal vesical breath sounds with no added sounds. Per abdomen, truncal obesity was present. Otherwise, abdominal examination, abdomen was soft. Tenderness was present over the right hypochondrium, but no organomegaly present. CNS, patient had a GCS of 15/15 with no focal neurological deficit. Post-examination diagnosis, a 50-year-old male, occasional alcoholic, chronic smoker, who's a known case of systemic hypertension on medication falling under obesity grade 2, is diagnosed to have acute cholelithiasis and hence was planned for laparoscopic cholecystectomy.
Okay, so you can stop sharing. We will go into discussion about this particular patient as such. You can stop sharing the PPT. So anyway, with one of the important things what you have written is here in introducing the patient himself, you have written about his height and weight. Usually you need not have to write down height and weight and body mass index when introducing. We usually don't introduce the patient based on his height, weight, and body mass index, isn't it? So anyway, you have written there. But ideally, during examination, you can always write down those measurements. That is one important thing. And again, one of the positive things in your history, as far as the patient himself is concerned, this introduction of the patient, he is a bank employee, isn't it? So does it have any positive thing regarding his being an obese patient, especially truncal obesity?
Sedentary lifestyle.
Yeah, sedentary lifestyle. One is a sedentary lifestyle. So that is the reason probably the probability of his having a obesity, truncal obesity, or whatever he has now. And this truncal obesity, actually, it's an android type or a gynecoid type of obesity?
Android type, sir.
Android type. Whereas gynecoid type of obesity, where do they have the fat deposition?
Hips,
thighs.
Isn't it? So that is the difference between android and gynecoid type. So anyway, these male people usually, and especially the patients with who are on sedentary lifestyle, may develop, increased abdominal girth, and they may develop android type of obesity. Yes, another thing is he's a bank employee, so he is a literate fellow. So definitely whatever the history he can give, so you can definitely rely on that history. So that is another important thing. So when you are asking about the history, because you know that these obese patients, they're highly prone to have coronary artery disease, isn't it?
Yes, sir.
So you should take slightly more in detail about the history of coronary artery disease in these patients. So because you have just written that no history of chest pain, so that may not be enough. So, many of these patients may not develop chest pain because they don't move. Many of these obese patients, they don't want to move. They just, very slowly, if at all, if they move, very slowly they may be moving. And that is the reason, even though they have a coronary artery disease, they may not come out with the typical symptoms of coronary artery disease. But other thing, very important here, you should have elicited the metabolic equivalents in this patient. So because in your history, that becomes a very positive history, because we know that coronary artery disease is very common. So at least we know that 2014 guidelines typically says if a patient comes for any high risk surgery or elevated risk surgery, you always look for the metabolic equivalents. If the metabolic equivalents are more than 4, you need not have to subject the patient for further non-invasive or invasive cardiac tests, isn't it? You can directly take him up for surgery. So that becomes so important. And as we know that obese patients are highly prone to have coronary artery disease. So in the history, you have to get the metabolic equivalents. Some you may have to subject him for non-invasive cardiac tests.
Testing,
So that's the only way. That is the reason, it is always better to get a proper history and also ask about his whether he has got any osteoarthritis, because that is very common with obesity. So the second thing is the stop bang. The stop bang you should always mention in the history itself, because stop bang is a questionnaire, isn't it? You don't mention stop bang in the exam. You have mentioned stop bang in the exam 5/8, isn't it? So, Nina, can you just tell what is the stop bang? And very important questionnaire. Expand on it.
Stop bang. SS history of snoring, sir. T is
Is just snoring or significant snoring? What is significant snoring?
is disturbing their partner's sleep.
If they're sleeping in the same room, or if they're sleeping in the other room, both rooms locked.
Not sure.
Now, significant snoring is the persons who are sleeping in the next room with their doors closed,
Closed.
locked, and their sleep is disturbed because of this snoring. That is what is called as significant snoring. S stands for significant snoring, because many of us snore, but very lightly we may snore, isn't it? But it may not disturb the sleep of the others. So that is what is significant snoring. Okay. What T stands for?
General tiredness throughout the day.
Okay. Why tiredness actually? What is the cause for tiredness? These patients can have.
work of breathing. There is increased consumption of oxygen for the patients because of this excess obesity. So
Everybody who is obese should have tiredness, as you are telling. Now, why these OSA patients? Because stop bang is mainly for obstructive sleep apnea. So what is happening in the night? Are they able to have a proper sleep?
inadequate sleep.
Inadequate sleep. That inadequate sleep is making them tired during the daytime. They'll not be able to work properly, because sleep is very important, isn't it? That is the rest, absolute rest to the whole of the body, and including the brain. we get during the, when we sleep, so that the next day we can be very fresh and then active. So because these patients are not sleeping properly, they cannot be active. So they become very tired during the daytime. Okay. Daytime tiredness, right? Then
Observed apnea, sir.
O is,
Observed apnea.
Observed apnea, sir.
yeah, okay. Apneic spells, isn't it? So what is this apneic spells? Why they have this apnea? These
Because of this,
yeah.
there is fat in this pharyngeal wall tissue. So on lying down in supine position, so they tend, because of the gravity, they tend to fall back and obstruct the airway. And also, while during sleep, there is a reduced basal muscle tone. So that also will add to the causing obstruction to the airways.
No, because as long as they are awake, they may not have any obstruction. Though there is, what happens is obesity and the pharyngeal circumference or area are inversely proportional to each other. If higher the obesity, smaller will be the area in the pharynx. Because as you said about the fat deposition inside the pharyngeal wall, so it becomes more narrow. So as long as they are awake, they'll be able to counter this narrowed area in the pharynx. So they'll be able to breathe well. But once they go to sleep, as you said, that all the muscles will become decrease tone will occur in the muscles. So there can be collapse of the pharynx. And once there is a collapse of the pharynx, total obstruction to the airway. And because of that, total cessation of breathing can occur. Either total cessation of breathing or partial cessation of breathing. That is what we call it as obstructive sleep apnea or obstructive sleep hypopnea. Those things are always there. So that is the reason why that the apneic spells in between. That O stands for an observer, because the patients may not know about it, that they are having this apneic spells. So somebody who is observing can definitely say that these patients had these kinds of apneic spells. Okay. And P is
Blood pressure.
Pressures.
yeah, invariably they are hypertensive. Your patient is also hypertensive. Okay. Then back
BMI more than 35
35.
kg per meter square, sir.
okay.
35. Back
Age
age
greater
more
than
than 55 years.
50 years.
50.
Neck circumference.
Neck circumference
Greater
more
than
than
40.
40 centimeters, sir.
Okay, okay.
And
And
last
gender, male gender more prone.
Okay. So all these are fine. You said that when do you say that patient can have significant OSA?
More than it can do
maybe
5.
3 fact,
More
4
than 3. More than 3 is significance for OSA. More than 5, definitely severe OSA can be there. Then why should you, what is OSA as such? Can you define obstructive sleep apnea?
It is cessation of sleep for more than 10 seconds when a
Cessation
patient,
of breathing, not
cessation of breathing for more than 10 seconds with patient taking adequate inspiration. With adequate patient's efforts.
adequate inspiratory effort, in spite of patient
Patient's
adequate inspiratory efforts.
There is cessation of breathing for more than 10 seconds.
With saturation dropping to more than
94, 3 or 4%.
more than 4% drop in the saturation, isn't it? So complete cessation of breathing for more than 10 seconds. And how many times in an hour?
5.
Yeah, more than 5 times
in an hour.
In an hour. More than 5 times in an hour. Okay. What is obstructive sleep hypopnea? How do you define hypopnea?
There's no complete apneic spell, sir. Decreased.
Partial cessation of inspiration.
Okay.
It is not complete cessation of breathing. It is partial cessation of breathing. So because there is an obstruction, more than 50% obstruction may be there. And this again can occur almost about 10 to 15 times an hour. And for with saturation falling to more than 4%. So that is, hypopnea. So when you combine apnea and hypopnea, what you get is apnea-hypopnea index, isn't it? So that is what is more important for us to know the severity of OSA, apnea-hypopnea index. So how do you get this? What is this? How do you classify this, the severity of OSA based on apnea-hypopnea index?
So I think it's a grading from 5 to 15.
Yeah, 5 to 15.
15 to 15 to 30 and greater than 30. So
16 to 30, 16 to 30 is moderately severe OSA, and above 30 definitely is severe OSA. So, and these things usually, you cannot, by history, you cannot get these things. Whatever the apnea, hypopnea index and all those things. So how do we get these things, apnea, hypopnea index? The patient has to be subjected for what?
Test
polysomnography.
Yeah. So the patient may have to be subjected for polysomnography. And with the polysomnography only, you can know what is this apnea, hypopnea index and what is the severity of OSA. And now, what is the importance of patient having an OSA for us as anesthesiologists? Because invariably, you'll be asked a lot of questions on OSA. And that too, your patient already has got a 5/8 of stop bang questionnaire. So definitely he has OSA. And what is the importance of knowing that this patient has got an OSA as far as your anesthesia management is concerned?
So it will have various effects on different parts of the like CVS respiratory system. In CVS, it will cause biventricular failure because of hypoxic events. Also, even
No. Go slowly, especially in CVA. Why the patient can have so OSA can mainly produce right ventricular failure.
yes,
It
first
may not produce the left ventricular failure. Left ventricular failure is because of something else.
Okay.
So why patient can develop right ventricular failure because of OSA?
Because of this hypocapnia and hypoxic spells, they will lack
Regarding is hypocapnia or hypercapnia?
hypocapnia, hypoxic and hypercapnia.
Hypercapnia. That is okay.
So
Hypoxia,
hypoxic,
hypercapnia.
these spells will be there, so that will cause the sleep fragmentation will be there. So for patients, so what that happens is like they activate sympathetic system in the body, and that will trigger release of hormones, stress hormones, cortisol and noradrenaline. And because of that, they will cause vascular remodeling. So vascular remodeling will finally lead to pulmonary hypertension and lead to right heart ventricular dysfunction.
No, just hypoxia, and what is the effect of hypoxia and hypercarbia on the pulmonary vasculature?
Because
Pulmonary
hypertension.
No, you see, hypoxic pulmonary vasoconstriction. Isn't it? Even hypercapnia also exaggerate this hypoxic pulmonary vasoconstriction. So they have repeated spells of this hypoxia and hypercapnia in the night that produces quite a bit of hypoxic pulmonary vasoconstriction. After some time, this will lead to pulmonary hypertension, isn't it? And pulmonary hypertension is an increase in the afterload for the right ventricle.
Yes, sir.
So initially the right ventricle hypertrophies, then dilates, and then goes for failure.
Yes.
So that is one of the problems in these patients. They can have the right ventricular failure and can have chronic carpulmonary, just like patients with COPD have. So these patients also can have carpulmonary. So it is very important to know about this. And when you examine these patients, you should also look for whether signs of pulmonary hypertension is there or not, and also to know whether they have carpulmonale is there or not. So what are the signs of pulmonary hypertension? You should have looked for that because it is not there in your examination. I'm just asking. Pulmonary hypertension, signs of pulmonary hypertension. Of course, symptoms, they can have tiredness, fatigue, all those things will be there, breathlessness. And also they can have, failure means they can have even edema, right ventricular failure, edema, raised JVP, tender hepatomegaly, all those things can be there. But pulmonary hypertension, you look for whether P2, pulmonary second heart sound, is palpable. Majority of the times, whenever pulmonary hypertension is there, P2 will be palpable and P2 will be loud. And they can also have right ventricular hypertrophy, parasternal heave can be there. So these things you should always try to look for when you are examining the cardiovascular system of these patients, but very difficult to elicit these signs of pulmonary hypertension in a morbidly obese patient, because you may not be able to feel these things because of so much of a part of fat that is present in front of the chest. But you should always look for these things. And what is the other main problem as far as OSA is concerned for us as anesthesiologists?
Reduced FRC, sir, and also
So those
reduced.
things are routinely with all obese patients. We'll come to that.
Okay.
Pathophysiology of obesity. So OSA, specifically for OSA. One important thing regarding OSA is the airway problems. And they are extremely sensitive to sedatives.
Overexposed.
And it is better not to sedate them even in the night, previous night. You do not give even mild sedative for these patients, because there was one case report that was published. Actually, a patient with history of OSA was posted for a hernia repair. The previous night, he was given a very mild sedative, a benzodiazepine. And next morning when the attendant went to wake up the patient was not waking up. That had produced actually in the night a lot of apneic spells, and the patient had gone for severe hypercarbia. And he had gone for carbon dioxide narcosis, and then he was not waking up. So immediately the anesthetist was informed. The anesthetist immediately shifted him to OT and then started ventilating him. And after some period of ventilation, he could open the eyes once the carbon dioxide levels dropped. So that is why, OSA patients, you have to be extremely careful in even sedating them as a pre-medicant. So that is one important thing. And again, second thing is, the OSA patients, it may be a very difficult airway. And, difficult airway means difficulty in mask ventilation, difficulty in laryngoscopy and intubation as well. And these patients, it is always better to go for awake fiber optic intubation. And then first, get the airway and then induce. So these are some of the real problems with OSA. And again, the post-operative period, again, these OSA patients, you will have a lot of problems. They may be already on a CPAP device, and you may have to go for a CPAP or a BiPAP, whatever they have, even continue in the post-operative period. So that is another important thing we should always look for. So the other important thing about your presentation is some of the measurements which are very, very important for obesity case presentation, you have not done actually. What you have done is, of course, height and weight you have done. So that is for calculating the body mass index. So what is body mass index?
It is a method to calculate how much percentage of fat we have according to the height and weight.
No, it is not what is the fat. For classification of obesity, you do a body mass index.
Mass index for classification purpose.
Obesity. So how do you calculate the body mass index?
Use the Quetelet's
formula.
Yeah,
That is
weight by square.
Weight in kg by meter square.
Weight in kgs divided by height in meter square. Okay, so based on that, you classify the obesity, isn't it? So how do you classify the obesity based on body mass index?
And start with 18.5 kgs. Less than 18.5 kgs is marked as underweight. 18.5.
You start with obesity. Don't worry about underweight or underweight.
18.5 to 20.
Classify obesity, yeah.
Okay, is normal. 24 to 27 in one book says it is overweight.
It is slightly different for Asians and different for whatever we get from the textbooks are mainly for the Western people, not for Asians.
All right, sir.
Asian community is up to 23 or 22.9 is normal. Anything 23 and above is overweight, up to 29.9.
Okay, sir.
And above 30, you would call it as obesity. Okay.
Obese, sir. Class
So,
1.
class 1 is
From 30 to 39.5.
30 to
34.5.
35.
okay. You can even say 30 to 35 like that, no problem.
Right, sir. 30 to 35.
Okay.
Then 35 to 40 is class 2.
Hmm.
And
More than
more than 40
is
is class 2.
super obese.
Okay. And more than 50?
Super
Obese.
Yeah, super obese. Super obese, super obese. That is there in Barash, he has given. So if you have super obese, then definitely you'll have more problems in managing the patient. Okay, so that one thing you have done, and what you have not done is to know whether this patient has got syndrome X or not. For knowing syndrome X, you'll have to measure the abdominal girth or waist circumference. Okay, so what is syndrome X or metabolic syndrome?
It is a syndrome in which it is characterized by 3 things: truncal obesity, BMI of greater than 34, insulin resistance, and dyslipidemia. So that is triglycerides greater than 150 milligrams.
Okay.
HDL greater for males greater than 40 and females greater than 50.
Greater or lesser than?
Sorry,
Lesser
lesser, sir.
than
Lesser. Lesser.
HDLs will be lesser than 40 for males and 50 for females. Okay.
Females. And BP of greater than 130 by 90.
The hypertension, usually.
These features are there to show that the patient is.
Why should you know whether the patient has metabolic syndrome or syndrome X? What is the significance of metabolic syndrome? They are highly prone for major adverse cardiac events, MACE, which is very important for us. If a patient has a metabolic syndrome, he is more prone for developing major adverse cardiac events intraoperatively or in the perioperative period. And even the sudden cardiac death is more common in these patients in the postoperative period. So that is why metabolic syndrome is important and we have to know about. So that is why you have to measure in all cases of obesity. You have to measure the waist circumference. You have to measure the hip circumference. You have to know what is the significance of waist circumference and waist hip ratio.
Sure.
And also you should know about the waist to height ratio.
Sure.
So these are some of the important measurements you have to do in all obese patients. Why I am telling you is this: you have in your examination, I did not find these things. Waist circumference. So when do you say waist circumference is significantly high in males and females?
More than 100 for males and greater than 102 for females.
No.
The ratio should be
Greater than 0.9.
The waist circumference itself is actually more than 102 for males and more than 88 for females.
Okay, sir, 88.
88 centimeters, both centimeters, 102 centimeters, 88 centimeters. For females, you will say it is higher because, females are supposed to have a narrow waist and males are supposed, that's why android and gynecoid type of, obesity also we will talk about. And what about the waist hip ratio in males and females?
0.9 and 0.8, sir.
You can say 1 in case of males, waist hip ratio, and 0.85 for females. 0.85 for females. Okay, so that is one more thing. Always measure the waist circumference. Take your tape always with you, when you go to the examination, and waist circumference. Where exactly you measure the waist circumference? And where you measure the hip circumference?
the level of the umbilicus is the
At the level of the umbilicus is waist circumference. Hip circumference?
anterior superior.
Superior leg spine.
Yeah, anterior superior leg.
Broadest.
Yeah, so you know about these things, but Somehow you have forgot to measure these things, but you should always measure. One more measurement